effectiveness and need for medications for opioid use disorder in benefit arrays. So we can do a little bit of a deep dive here in the remaining time. Aim one of the study, as I promised, is to develop and administer a national survey to all state Medicaid and children's health insurance programs, as well as those programs that operate in DC and the territories, and to all of the managed care organizations that they contract with. And the goal here is to identify the determinants, the mechanisms, and intermediary characteristics that influence these policymakers' behaviors seeking out, receiving, and using research to define their benefit arrays. So this is really kind of two surveys here. The first is kind of a factual survey, just basically confirming what they do cover, which medication types, what's on the formulary and the preferred drug list, and what kind of utilization management strategies are being applied to each medication. Is it prior authorization, reauthorization, step therapy, things that we mentioned earlier. And then the meat of this, and really the heart of the study, is the second part of the survey, which is about the evidence use behaviors. So understanding what type of, how often do they revisit these benefit decisions? Sadly, a lot of research has shown that sometimes Medicaid benefit arrays don't change over the course of a decade, but we know science moves faster than that. So these web surveys are going to staff at all Medicaid and children's health insurance agencies across all of the states and territories, as I mentioned, and also to the MCOs. And there's probably about 260 managed care organizations last time I checked that are contracted to administer these benefits. So this is hopefully going to be a robust database, but that is not without its own challenges, which we can talk about. And the key respondents of this survey are agency leaders. So not necessarily the Medicaid directors, although they'll certainly be outreached, but I'm thinking about the medical directors, behavioral health directors, pharmacy benefit managers and staff, and others engaged in these decisions about medications for opioid use disorder coverage. And then the idea here is to essentially aggregate all of these individual level survey responses within each agency or managed care organization to the organizational level, so we can understand how the organization is functioning. What is their evidence use culture like? And so we'll be using agencies and managed care organizations as the unit of analysis for the survey data. And that's really with the goal of designing dissemination strategies that are tailored to their agency or tailored to their managed care organization's behavior, rather than to the individual needs of different staff members that might have varying roles, responsibilities, influence, and who might turn over the next year or so, right? And this also prevents us from deploying conflicting dissemination strategy messages to colleagues in the same agency or organization. So this is kind of a fun slide, and I will be taking feedback on this. So I'm toying with the idea of calling this the Policy Wise survey. And there's a very sad PowerPoint-driven logo created for this. So anyone who has more graphic skills and clever acronym titles, feel free to offer your suggestions. But here's a summary of some of the questions that we're looking to ask. Do Medicaid and children's health insurance programs share leadership and staff, or are they really different organizations with different evidence use behaviors and implementation climates? How is the Medicaid director selected? We see in a lot of states that sometimes these are folks who are appointed by a governor, and so they might be appointed to carry out a political agenda around Medicaid benefits. In other cases, they just might be sort of street level bureaucrats, right, that rise through the ranks over time and assume these positions. I'm also curious when legislative approval is needed in some states, because that does differ. And so even if the Medicaid agency wants to create a very robust evidence-driven benefit, how might legislative approval change that or impact what they're actually able to pay for? And how often are they revisiting these decisions? So that's a bit about the agency characteristics that we'll use as indicators for the latent class analysis. But again, the heart of this is about the evidence use behavior. So here's just sort of short versions of some of these questions. How likely are you to use information from a variety of sources? And so we'll ask about personal knowledge or colleagues, an academic researcher, advocacy groups. How often are those sources of information consulted when benefits are designed? And then what type of information they're using, work group recommendations, data on cost effectiveness for the medications, things like that. And then how likely are they use are they to use information presented in different formats? And this is going to get at how they want to receive information, right? So do they want to see policy briefs? Do they want something more interactive like a workshop or technical assistance or expert testimony? What's the best way to reach them? Because again, we know that they're not reading journal articles. Um, and then there's also some items here from the Research Dissemination Barrier Survey, which essentially gets at why they might or might not use research, their capacity to use research in a meaningful way. And also there's a 6-factor model of evidence-based decision-making scale that measures some of those items as well. An important component of this is stigma, right? Because we know there's a lot of stigma, not only toward Medicaid, folks with opioid use disorders, but also receipt of medications for opioid use disorder. So there are some questions in the survey about their belief that medications for opioid use disorder are safe and effective and helpful for recovery. We'll also ask some questions that get at some of the stigma, right? So something I hear a lot from policymakers is, isn't providing methadone just replacing one drug with another? Which obviously the evidence says like this is not true. This is treatment in and of itself. But so we need to get at that so we can understand what type of information we might need to start coming to these policymakers with. And then finally, there are some questions from the implementation leadership scale. And this really gets at how knowledgeable and supportive is your supervisor or the leadership in your agency for the use of evidence-informed decision-making. So as I mentioned, I'm expecting to see a lot of variation in this national study, right? Again, if we know one Medicaid agency, we know one, they're all super different. And doing a study of all 50 state agencies plus DC and 5 territories, no doubt we'll see even more heterogeneity. So latent class analysis is the approach to deal with this problem. So this is a finite mixture model approach that moves beyond those differences to identify and classify agencies or organizations into subgroups or latent classes based on patterns of responses to some of the key observed inner and outer context and bridging factor variables that we went over. And again, latent class analysis is really cool because, right, it maximizes homogeneity so that folks in the same class are as similar as possible, while also maximizing heterogeneity between the classes to ensure that the classes are indeed mutually exclusive. And so some of the probable indicators we'll be using for this is the need for legislative approval to change benefits, partisanship measures to see how that influences benefit design and coverage, agency structure, and of course the decision-making behaviors and preferences, as well as implementation leadership and preferred intermediary types. Who do they trust to get information from? But that part of this is exploratory, so we'll see what happens there. You know, I think this is interesting because something I'm expecting to see with this latent class is that Medicaid agencies and their contracted managed care entities might actually be in different classes and might have different evidence use behaviors and preferences that we need to address. And so I'm expecting to see some sort of misalignment between those preferences and evidence use behaviors. But that's cool because once we measure it, we can do something about it and design dissemination strategies in a way that's really meaningful. The other really nice thing about using latent class to identify these groups is that it allows for unanticipated classes to start emerging in the data based on observed determinants of their evidence use, rather than me as a researcher saying, I know what the most important indicators are, or I'm going to group them in a way that makes sense to me, right? I'm taking my assumptions out of it on some level. So for the latent class analysis, we'll be doing some descriptive summaries to describe these latent classes, and that will hopefully be useful information for not only developing tailored dissemination strategies, but also just helping us as researchers understand the different evidence use behaviors out there. And in order to validate that these are real classes that really do exist, I'll be sort of presenting the latent classes and descriptions of them, their preferences, what makes them in that one class versus another, to a small group of Medicaid policymakers to get their feedback and tell me, hey, are these, you know, does this look familiar to you in your experience working with these agencies? Does this look like you and your colleagues? And then all of this sort of culminates in designing adult and youth class specific policy dissemination strategies, with the common aims of facilitating evidence exchange between agency and managed care policymakers and research-driven intermediaries, sort of overcoming some of the noise of other intermediaries who might not be as evidence-driven. And ultimately, of course, promoting the uptake of evidence-based benefit arrays that include all medications for opioid use disorder with evidence-informed utilization management strategies. And so we're using this sort of 10-step process that I developed with my team to develop and specify the strategies, and I'll show you that on the next slide in case it's of interest. But once those strategies are developed, we'll be pilot testing these. And so we'll identify one agency or managed care organization from each latent class in AIM2 and ask them to participate in the pilot study, testing these tailored dissemination strategies. So each participating agency or managed care organization will be assigned strategies tailored to their class and strategies that are tailored to other classes. So the idea here being they'll be receiving matched and mismatched strategies based on their own evidence use behaviors, with obviously the goal being that the matched strategies work a lot better than the non-matched strategies or the mismatched strategies. And I'll be asking these policymakers to complete some survey questions evaluating the acceptability or satisfaction with the content that's put in those based on what we learned from the latent classes, preferences, the appropriateness of the dissemination strategies. Are they relevant? Is the information provided in them useful? Is it timely? And what's the feasibility of these strategies? Meaning, how practical is it to use evidence from them in their everyday policymaking behaviors? So here's sort of an overview of our process for creating tailored dissemination strategies. And this is sort of a lot to look at on a table. And I know there's a big glare coming in from these wonderfully bright windows. But essentially, we want to think about how do we, identify the message target, if we find in an agency that a lot of their benefit design choices are driven by cost, then cost needs to be the thing that we focus on when sharing information about medications for opioid use disorders. And then we'll look and see if that message target, right, is it aligned with the research that's happening right now? We'll think about what's the outcome that we want to change. Obviously, it's benefit design if it's a non-evidence-based benefit. And then think about, how to present this research to folks. What's the preferred source of evidence to receive it from? What kind of messaging? How can we make it a data-driven, evidence-based message to help inform their decision-making process? And specifically, who should receive this message? Which person is making the decision? Is it a medical director? Is it someone else? Is it a few people? And then also, thinking about how they want to receive this in terms of, is it a research summary? Is it an issue brief? Is it a short email communication? Is it technical assistance? When do they want to receive it? How often are they revisiting benefit designs? When does a policy window open so that they can actually address this? And think about, how often not only when do we deploy this, but how often we deploy it over time. Do they need it once? Do they need it multiple times? So hopefully this study will address some of the black box policy making that is prevalent in Medicaid benefit arrays, and it'll illuminate some of the key determinants, mechanisms, and intermediaries or purveyors of information that these Medicaid agency and managed care policymakers trust to receive evidence from. But it'll also help us identify ways to reduce the research to policy gap by designing tailored dissemination strategies, right, that generate knowledge about how we should be better communicating our research to policymakers and when we should do it and in what ways. So I'm going to wrap up by sharing a couple of takeaways, right? We covered what is dissemination and implementation science. Typically, it hasn't focused on policy level factors too much, but I think that that's sort of a misstep on our part as implementation scientists. There's a lot that we can learn about policy implementation research from political science and public administration scholars. But what we can offer is also thinking about how to design, tailor, and test strategies that promote the implementation of evidence-informed policies and also promote the use of evidence in decision-making and policy-making processes. I also think that policy-focused D&I strategies can probably help us address the research to policy gap. I'm curious for your thoughts on that. We talked about a really sticky problem, really effective research that medication for opioid use disorders work. Sometimes evidence-informed, sometimes less evidence-informed policies, but nonetheless, this misalignment leads to inequitable access to medications for opioid use disorder, and this is very dramatically shown in the Medicaid program. But hopefully targeted dissemination strategies can promote evidence-informed policy designs and ultimately more coverage of medications for opioid use disorder. So I'll stop there. Thank you so much for your time today, and I welcome any questions and feedback. Yeah.
Do you want to just field questions?
Sure.
Okay.
You have a couple right here.
That's great. Yeah, go ahead.
As your research evolves, how that player or that piece of the framework plays into it. Just knowing, for example, that a lot of patient populations that have these types of disorders also have larger social complexities that inevitably spill over into other state agencies beyond Medicaid. I'm particularly thinking of what CMS just announced yesterday around justice populations and kind of the continuity of care across justice facilities into the community. I just foresee a dimension there of like not only like managed, like, you know, what's listed as a benefit under Medicaid and then what's covered under the utilization management of MCOs, but like what is even available in a facility and how do you rectify those two? Obviously, we're very new at that, but I'd just be curious on your take as this unfolds, like where you potentially seeing that, and that's just like one population that could be considered.
Yeah, that's a fantastic question and a very hard question to answer. So yeah, we are considering how Medicaid agencies work with other state agencies that are influenced by them, and who foots the bill for a lot of these services, right? So we know in some states, Medicaid agencies stand alone. In other states, they're part of a larger Department of Health, right? And they're one department or division within that larger health authority. So it'll be curious we are going to measure, you know, how often they work together, what kind of information they get from these other state agency actors to inform their decision-making process. So that'll help us start to understand that dynamic a little bit better, because a lot of states have traditionally been siloed, but they're moving toward more integration and coordination of services. I'm curious, you know, part of my research focuses on the criminal legal involved population because there's a lot of crossover. These folks are usually eligible for Medicaid as well. And so I'm really curious about the evidence use behaviors for folks involved in the Department of Corrections, right? How are they and their perceptions of medications for opioid use disorder influencing access to those medications in jails? Because it's not just about logistics. There's a lot at stake there to unpack. And so I've been thinking about that too as a potential, you know, next part of this project. Yeah.
Former Medicaid administrator who was stuck in that dilemma a lot, and not a lot of people were thinking about like our because of expansion, our populations were now coming from previous safety net systems that we were not speaking the same dialect, if you will, and we were causing some pretty potent disruptions in care, and it was just the tip of the iceberg. So I know it's a hard question, but I would say like it's going to be really helpful in the future. And then along that lines of your second comment, I'd just be interested to like around your thoughts on just stigma too, because inevitably if you think about a state that designs a benefits pathway, right, like it's a function of the political environment of the state. And so how does like the community stigma around you know, behavioral health writ large influence political structures, which then influences like whether or not some of these benefits are even covered.
Yeah.
And so to your point, like even the civil population, the end user and their own stigma, how it shapes their interaction of that system, I think is a pretty, for lack of a better phrase, pretty pregnant area of like, you could go into a lot of different areas and pack it. But overall, this was amazing. And as a medicated administrator, I'm like, this is very timely. So thank you.
Thank you so much.
Hi, thanks so much for this really interesting talk. I'm wondering a little bit about how you think about addressing gaps in what maybe end up being, policy or practice mandates. So I'm thinking specifically about there's a law in the child welfare space called the Family First Prevention Services Act that mandates the use of evidence-based practices. But even in the case where you have a mandate, there's still kind of an organizational gap between frontline practitioners who maybe you're supposed to ensure that patients or clients have access to a specific medication or a specific service, but the fidelity to that is much harder to track at that frontline worker level. So I'm just curious how you think about that. If we're moving in a direction to really encourage this policy and evidence-based practice connection, what do we then do about the frontline workers who are in charge of giving these services or these medications to actual clients?
Yeah, another totally fantastic question and complicated, sticky problem for us to address, right? So that's a really strong argument for multi-level implementation strategies or multi-level dissemination strategies. I think that, and largely our field is pretty good at the multi-level part of it, right? It's hard to address everything in one research project. But there's a case for coordinated efforts where, you can change how things look at the federal and the state level, but you need to be changing how things look at the organizational level and points of service, as you mentioned. And so I think that as a field, we need to definitely wrestle with that and think about how to do this in really coordinated, well-timed ways, because we can't fix one part without fixing the other. That just it shifts the misalignment, essentially. So yeah, it's not something that this study is particularly focused on, and largely I didn't focus on addressing that in this study because there's a wealth of other studies, especially with the wonderful JCoin initiatives and HEAL initiatives out there now that are focusing on improving access to evidence-based substance use treatment and the whole care continuum within provider organizations. So I'm letting those folks do that work, but definitely keeping my eye on it. And there's a fantastic researcher at Oregon Social Learning Center named Gracelyn Cruden who is dealing with the Family's First problem very closely in her research as well.
That's great. Thanks so much, Erika. This was really, really interesting. I have a ton of questions, but I'll ask just one of them. So one question I have is kind of in response to the disjuncture between, your main argument, right, that there's a huge misalignment between evidence-based research and policymakers. And one example you gave, and there are lots of reasons for that. And one reason is the way that researchers focus on outcomes is not the same as how policymakers might want to focus on outcomes. So the example you gave is, researchers might focus on costs and policymakers want them to focus on cost effectiveness. And so that all makes sense to me. But then I started feeling a little bit uncomfortable at some level of sort of like, how much do we just feed into what policymakers want if we think what they want is sort of a bit narrow, or they're defining the problem in ways that ultimately are not helpful. And so one example I have from quite a long time ago, but I think it might be a good one, is the Medicaid expansions in the 1980s really focused on pregnant women and children, pregnant women and infants, and pregnant women and children. And the whole argument at that time was that it's very cost effective to expand services to pregnant women and infants and children because of the high infant mortality rates, especially among women women and kids of color. And that evidence, I think, did lead to incremental expansions in the 80s, and then, ultimately, I think, led to SCHIP and what CHIP today. And so on one level, that's a really good thing. But it did create this kind of embedded discourse in Medicaid that you should expand the program, kind of population, small incremental population group by population group, only according to that which is cost effective, right? And you might argue we should, as we eventually did with the ACA, but still many states are resisting this, that we should expand coverage because everybody deserves a right to healthcare, right? So we kind of fell into that discourse when maybe in the long run, falling into that is not all that helpful. So just wondering, what do you think about this larger agenda in terms of trying to change the discourse? Like, do we fall prey to only operating within an incremental, kind of more narrow discourse? And what do we do about that? That's a big question.
It is a big question, and I appreciate you asking it. Uh, you know, that's sticky. Yeah, it's a real tension. And I agree. I think that some of these previous policy expansions have really led to inequitable access to care across the different populations that Medicaid serves. You know, what also comes to mind is when that doesn't work too. Like, we see a lot of states that initially, when there was the 1115 waiver opportunity to provide a robust substance use disorder treatment care continuum, a lot of states embedded a justice population or criminal legal involved population specific approach. And then it was funny, when I did research studying the implementation of those 1115 SUD waivers, I kept asking states like California, like, so what happened to the initiatives focused on the criminal legal population? Like, where'd that go? What do those benefits look like now? And they were like, that kind of like fell off our focus because we had to deal with other problems. And so I think that'll be a state by state problem that we have to look at in the data for sure. Like, what are the outcomes of interest, and how do those outcomes of interest compared to what their current benefits look like? Are there already existing inequities that these outcomes that they're interested in might sort of exacerbate, or might those outcomes help address some of those inequities? Like, are they looking for more social determinant oriented evidence around the need for medications for opioid use disorder, or are they just focused on the cost? And are they going to use that as a way to only cover the cost of these medications for pregnant women, right? It'll be something to definitely take a look at. And that's partly why I designed the project to separately ask about coverage questions and evidence use behaviors when they think about adult versus youth populations who are covered by Medicaid or CHIP, because I am curious and suspicious that those inequities exist as well.
Thank you so much. I'm curious if you can speak, like if you've seen in your research, so your project seems to be more focused on like state policies and like asking states individually, and then as you said, making like the three groups and then having different targeted approaches based on that. And so I don't know if you've done, or like basically in your research, like the balance between the federal policy and the state policy, if you feel like you know, if there's a harm of having a federal policy because a blanket approach might like be inequitable based on the different needs that states have, versus, you know, having, if you have a federal policy, then it'll be more like in terms of changing the narrative and getting these things pushed forward, it'll be like more helpful. So I know there's like a balance there, and I don't know if you could speak to any like research you've seen in that.
Yeah, so we're touching on the very complicated and interesting problem of federalism, right? Which folks in this room are experts in. Yeah, it's a great question, right? Because Medicaid is a joint federal state administered program. Something like Medicare is federal administered program. They're both public insurance programs, but they operate totally differently with different influences. Yeah, so does making the state Medicaid benefits does increasing the uniformity around coverage of medications for opioid use disorder across every state Medicaid and CHIP agency create problems for tailoring to the needs of the population? It's an interesting question. You know, I would argue that medications for opioid use disorder are first-line treatment for opioid use disorder, and the research shows that they are as effective without outpatient therapy as, with outpatient therapy. So it's really about how do we create access to them in the midst of an opioid crisis where people are, like I said, we're losing our friends, our family members, and our neighbors rapidly. And COVID exacerbated that problem. And so creating more access to this life-saving treatment, even if, it creates uniformity and access to it, like I would argue that that's a good thing. And I'm not terribly concerned about the federalism piece of that and state decision-making processes. I think ultimately state benefits won't look the same no matter what we do. I think that they'll differentially impose utilization management strategies that might make sense for their populations, right? So, and we can get into the specifics of that too. That's kind of a longer conversation. But I don't know. I'm not terribly concerned about that uniformity when the idea of it is to save lives and make sure that people at least have access to coverage of these evidence-based medications, right? Ultimately, it's the decision of the patient and their provider what their treatment plan looks like and what services that they can access. My goal is to just make sure all of those options are on the table to them when they engage in that treatment planning process.
We have some online questions.
Sure.
Adam Scheffler asks, what is the anticipated usefulness for changing decision makers' behaviors or producing different outcomes than we see now and have seen for 30 years? Also, even with positive results, how will those outcomes be diffused across relevant actors and organizations?
Okay. So, yeah, I mean, I think the idea is to figure out, we don't have a lot of transparency in the Medicaid decision-making process. There's some work on that, but not around benefit decision-making processes necessarily, at least not as much to really get down to the nitty-gritty of who's in the room when these decisions are happening. And also, how do we create the room where they happen and that they're revisited, right? Because a lot of our benefit arrays are outdated. And so I think the goal with this study partially is to figure out where those rooms are and who's in the room when it's happening, essentially, right? And start to figure out how we can change their decision-making behaviors in a way that just creates options for access to evidence-based treatments. And I think if I'm hearing that question correctly, Keith, part of that was, do we think this will really work? That's a fair question, and arguably the point of science too, right? Like, we might not think some dissemination strategy, we might think some dissemination strategies might be more effective than others, but the point of the latent class analysis here is to take me as the researcher and all my assumptions out of the process and say, what do the data show us empirically, how these dissemination strategies should be tailored to the needs of these policymakers? Because I would argue that I don't think we've been doing a great job over the last few decades of research in terms of figuring out how to reduce the policy or the research to policy gap. So hopefully this alternative sort of empirically data-driven approach helps to get at that in a more effective way.
Thanks, Colleen. I've got three questions, but I'll only ask one.
Okay.
Traditional medicine has been dealing with this issue of dissemination forever. And in the last 2 or 3 decades, there's been more focus on it in terms of best practices and all. Is there a body of research you can draw on that you can learn from when you're trying to disseminate issues like opioid use treatment? And because there's been so much that's going on, including in the pharmaceutical industry, doing direct-to-consumer advertising rather than trying to go through physicians to get medications prescribed. So, is there a role? Is there something we can learn from that? Is there something out there that you can learn from? And
Yeah.
and because it's an old problem in medicine. It's been there forever.
Yeah, this is a great meaty question. So okay, so dissemination and implementation science is a more recent sort of growing subfield within health services research. But as I mentioned, it's interdisciplinary, and we have a lot to learn from the disciplines that gave rise to it, right? And some of those disciplines include political science, right, which they've looked at how citizens and policymakers engage and put values on different policies, and sort of ultimately how those policies get shaped by, and what makes them more effective in terms of getting passed and things like that. Public administration has also done a lot here, but I think the communication fields have a lot to offer as we think about how to effectively design dissemination strategies. And of course, like you said, we can look at effective marketing campaigns by big pharma companies as well. It's interesting, you mentioned how pharmaceutical companies often go to direct-to-consumer marketing, and that's been a challenge in Medicaid, right? Like, there's a fantastic book that really piqued a lot of my interest in Medicaid policy issues that Dr. Grogan wrote, Unhealthy Voices, Unhealthy Silence. And it talks about the absence of advocates, in the room when people don't speak up. And so I am concerned, right, if we do start to focus on, if we designed a study where we were focused on encouraging Medicaid members to speak up and advocate for their benefit arrays and things, like how effective would that be? That's a great question. Someone should study that. I think Jamila Mishner does a lot of that kind of work. And there's certainly a lot to learn from there as well. So yeah, there are definitely many disciplines to draw on, a lot of great work in this space.
One thing that the direct-to-consumer advertising, can you hear me? There is the role of the power of the people that you're reaching. If we're talking about cancer care, consumers are really quite powerful. And in fact, a lot of what we're trying to do in implementation science or comparative effectiveness is to restrain ineffective therapies that patients want, that there's a lot of political pressure to pay for, that are not effective. And I just wonder how implementation science would look different if you had a population that was fundamentally more powerful, less stigmatized, more socially influential. Because it just seems to me it's fundamentally different enterprise.
I think that's
I thought that was going to be a question at the end of that, but as I was saying it, it sort of sounded more brilliant before I said it than after I said it.
It's a great comment nonetheless, Dr. Pollack. I agree. I mean, I think that's why, it's funny when I talk about my research at some conferences, I get weird feedback. I'll call it weird. I'll put that value judgment on it. I'll hear, take the politics or the partisanship out of this translation of evidence-based practices in our healthcare systems. Like, we're not advocates, we're researchers. Why are you dealing with partisanship issues? Or, are you really over, how many questions do you need about stigma? And I think that whenever you're talking about access, any kinds of services for individuals who use drugs, that's one level of stigma. And then when we think about access to medications for opioid use disorder, that's another level of stigma, right? Because a lot of folks in the treatment community might consider that not treatment, right? Like, we see a lot of barriers to folks joining NA or AA groups because folks in those settings will sort of say, well, that's not sobriety, there's another medication in there. And then when we think about Medicaid, gosh, there's no shortage of stigma. How deserving are people for healthcare services? How deserving are they of publicly funded insurance? I would argue everyone is deserving of it, but there are so many levels of stigma. So you're right. What would it look like if these were not the contextual factors at play? Yeah. Mm-hmm. Yeah. Well, I think it stems from a moral judgment that people shouldn't be using drugs, right? Or they shouldn't be accessing free healthcare, right? Whereas cancer, whose fault is that? Whereas substance use disorders, even though we can stay here in this room and know that substance use disorders are a chronic disease, other people might disagree with that. I agree.
it relates to a question that I had, which is, cost effectiveness sounds like objective, pure scientific research, but we know that what you count as effectiveness, just as Harold said, depends on whether you're counting effectiveness only to the patients or if you're thinking about the broader society or both, and all the other things that go into that bucket of value, right?
Yeah.
And then similarly, what gets counted on the cost side. And so there's a ton of assumptions underlying cost effectiveness research that really is just about our values, right? Like, what values do you bring to the table? And so I was curious, we can call that evidence-based research, and it's important. It's a very important research, but do we lay bare exactly what the assumptions are that underlie the different models so that we're having a very transparent conversation with policymakers? Kind of how do you approach that from a dissemination perspective, right? Or do you just say it's always cost effective and forget kind of getting into the details of what underlie the models? Yeah.
Yeah, that's a fantastic question. Okay, so I'm going to preface this answer. This is a great question. This is a great topic. I'm not an economist, so I'm going to put that out there. And cost effectiveness data is one option of, we think policymakers care about that, but there could be a lot of other outcomes that they care about, and I'm hoping that they do, because again, I'm not an economist and I don't want to keep doing cost effectiveness studies. So there's a lot of options that we could present them with, hopefully, for outcomes that matter to them. That said, it's funny, I've been having a lot of one-on-one conversations with Medicaid medical directors about this project, just to sort of gauge, take the temperature of like, how interested are people going to be in responding or participating in this study. And it's funny, they say things, these are medical directors, so consider the sample, but they're sort of saying things like, gosh, I don't know, like maybe cost effectiveness data will be important, but also I think there's an argument that health economists should kind of get out of healthcare, because we see a lot of economic arguments in the substance use space that are unproductive, right? There's a very famous paper that I won't give the name of because I don't want to give it more publicity, but it came out kind of, some economists evaluated the utility of naloxone, which is opioid overdose reversal medication, and they described naloxone parties where people intentionally overdosed because that naloxone was available. That's, of course, totally false. And that paper has a lot of problems and was ultimately, it was recalled and then it was edited. There's a lot of issues there with that paper. I think some folks are nodding. You might know what I'm talking about, right? So there's an argument about like what outcomes to present and the assumptions that go into any model, how you're evaluating what is cost, what is effectiveness. So I think, yeah, as researchers, we need to be transparent about our assumptions. And I think there's also a case to acknowledge that anytime we're advocating for an evidence-based practice or an evidence-informed policy, we're asserting a value judgment there that these things are more important to fund than something else, right? There are no politically neutral health interventions, because funding one thing versus funding another is prioritizing. So I think there is something about that. I do think researchers also probably haven't done a great job being transparent about the values that they bring to their research. And there's this hesitancy to acknowledge that, because we say, oh, well, that makes us look like advocates, or that makes us look like we're somehow less rigorous or unbiased. I still think that we have a lot to learn. We could, draw on the anthropology and sociology fields where they talk about their researcher perspective and researcher assumptions and positionality in their papers, right? And how that brought them to the research question, the hypothesis, and the variables that they measured. I think that we could do more in copying some of those methods and using it in our work to address the values that we bring.
Yeah, there was one more question online. When policymakers need to make decisions fast, what strategies would you recommend to speed up the process without compromising quality? Still stay evidence informed.
Yeah, that's a great question. So hopefully we find, hopefully the latent class analysis and the survey data show us what some of those strategies should or could look like. There are things like rapid evidence review. So I'm not sure if anyone is familiar with the McMaster Forum. It's a Canadian-based institute, and they're really great at doing, they're a WHO-funded institute, and they're really great at doing rapid evidence reviews and disseminating them to policymakers during the legislative session when they need information. So I think it's about being nimble, but I think in order to do that in a really rapid way, it's also about building those collaborations and building trust up front so that you are getting the request for information as soon as it comes up and is relevant to the policymaker decision-making process.
When you were mentioning the policy briefs as potentially a mechanism to engage policymakers directly, I'm wondering who would be writing those, if that would be like researchers that have policy experience or members of their team, or partnering with an external maybe organization to help write those memos or briefs to allow for this more fast dissemination of research and also to bridge that partnership to have more of that back and forth, what's useful for both parties in those partnerships.
Yeah, I think any of those options, it's a great question, Caroline. Any of those options could be relevant, right? So policymaker, or if policymakers are saying they want policy briefs, we have to have researchers who know what a policy brief really is, and they know how to write one effectively. Because I see a lot of policy or researchers say, oh yeah, I wrote a policy brief and it's like 5 pages long. And I'm like, what is that? I don't think that's brief, and I don't know what policy that's going to inform. So I do think that researchers probably need the skills to write a policy brief in order for that to happen. And so then the idea becomes what organizations might be well positioned to do this and might have expertise in doing this, and can they work with the researchers to understand, interpret, and synthesize the research, but then communicate it more effectively. And we see that all the time, right? That's not different than if you see an op-ed in any newspaper that's written by a politician. I guarantee they didn't write it. There was a ghostwriter, a team that helped them write it with their ideas, but just communicating it in an effective way to that audience. So I think the same could happen here for policy briefs.
We have to end it here even though there's more questions, I'm sure. Thanks so much.
Thank you so much.